Season 2 of the Pitt is here. I'm hyped. Hope you are. They're also greenlit for season 3. Let's get started. Whoop. Where's your helmet, buddy? Come on.
Morning, John.
Could have sworn it was still around 4 a.m.
You guys have an easy night last night? The waiting room actually looks manageable.
You know what I like to compare an ER shift or just a night shift when you're on call and you're in the hospital all night? There's a little bit of a runner's high that you experience once you finish it because you feel so happy to be free and that you've survived this shift. They need to have, like, instead of shift work disorder, shift work euphoria once you survive the shift.
Please, Jesus, please.
Hail Mary again.
In the sanctified flesh.
Don't let me die alone.
Just try to relax, Margaret.
I need a priest.
Hey, Dr. Robbie.
What's the good word, Perla?
All your results came back normal, Mrs. Walker.
I'm dying.
You're not dying, Mrs. Walker, I promise.
A good follow-up question there would be, why do you feel like you're dying? What symptom are you experiencing?
Don't worry, Margaret. We're gonna have the hospital chaplain come and see you in a moment.
I'm not gonna last that long.
Yes, you will, because we're gonna give you a shot to keep you alive until they get here. What are you thinking, Dr. Rabinovich? 500 mics of cyanocobalamin?
In her condition, I'd push a full 1,000.
Whew. A little B12 goes a long way, but I'm not a fan of just giving people injections or medications unless they absolutely need them. Perhaps they have experienced a history with her where she does have anemia related to a B12 deficiency, so perhaps they are acting in her best interest.
My husband is still waiting to see a doctor.
I apologize for the wait, but here are 2 doctors.
I love that there's a dog in the purse.
Mr. Burgess has been complaining of leg cramps for a day. Slightly tachy at 110, BP 128/75, afebrile, good sats.
Great presentation. The only thing that's confusing me about their handoff, and we have these handoffs typically when the day shift comes to take over the night shift. Usually we do this either rounding together as a team, or we do it in a separate room where we pass off information related to blood tests, pending results, so that we can keep notes. And also, we usually drop our stuff before we do it. He's doing it full on in his jacket.
I'm Dr. Shen, but I'm going off shift. Dr. Rabinovich will be one of the doctors looking after you.
What other medications are you currently taking, Mr. Burgess?
I brought his meds.
Thank you.
These are his supplements, mostly all natural and organic where possible. And these are his homeopathic prescriptions.
I don't know what a homeopathic prescription is. Legit. Like, I don't even know what the definition of that is. I like when patients bring in a bag of medications because at least I know what medications they're on. So often patients and family members, caregivers are unaware of what meds they're on. And that creates a very confusing cycle of having to call the pharmacy, finding out what they filled, making sure that's the main pharmacy that they use, not a second one, because the second one offers them a cheaper price on some of their medications. And as a result, when you're having to take this many steps to clarify what meds they're on, mistakes are bound to be made. Or simply, in this day and age, write it down on your phone, or perhaps have access to one of your My Charts where all that information would be stored. One of the biggest problems with supplements, probiotics, naturopathic supplements in general, most people are unaware of the interactions with pharmaceutical medications and perhaps with conditions that they have. It could be making their true medications that are keeping their bodies alive and functioning not to work. It can literally lead them to not be as effective. And what we've seen is, like, using melatonin as an example, especially with gummy melatonin supplements, what's tested that's sold on the shelf has like 75% to 300+% of what's listed as an ingredient in the supplement. So, like, you got to be so careful. And when I say so careful, I don't even know what you're supposed to do, because what are you going to go home and test how much melatonin is in your supplement? FDA needs to regulate.
Where the hell is everybody?
Our new attending is torturing our intern and med students in Trauma 1. She came in early to meet the night shift and took things over.
Okay. So, tell me about this new attending.
She's pretty, divorced, 1 kid. Can already tell she is a strict rule follower. I'm probably gonna grow to hate her.
What is interesting in referencing that she's a strong rule follower, that can be difficult to work with in an environment where you constantly have to call all audibles, like in the ER, because it's not just about following guidelines, it's about adjusting to the situation, to each individual, and sometimes everything goes out the book. As we saw with the mass casualty incident episode, they were charting, they weren't documenting. It was just about giving patients quality care that you can give in a moment of crisis.
Off the chest, Ogilvy. Get ready to step up here, Joy. Ogilvy, off the chest.
Clear.
Still VTAC, but it looks weird.
When someone has a cardiac arrest, essentially you need to start CPR right away. That's why we're always yelling chest compression, chest compression, chest compressions. You also, because you're in a hospital setting and not just on the street watching someone collapse, you're also wanting to attach a defibrillator. The defibrillator will be able to, after doing 2 minutes of CPR, evaluate whether or not the rhythm is shockable.
Analyzing. Shock advised.
Sometimes a defibrillator is not one that will make the call for you, like they have here in the hospital, where the residents actually have to look at the rhythm and decide, is this a shockable rhythm? For example, a non-shockable rhythm would be like asystole, flatline, which is why I find it hilarious on other medical shows when someone goes beep, flatline, and they go, get the defibrillator, get the paddles. You do not shock that rhythm. For the other side, you want the shockable rhythms, you have ventricular fibrillation or pulseless VTAC. And in those situations, you are doing CPR, but you could also administer a shock after you have 2 minutes. You also have to make sure everyone's off the body and not also getting shocked by making contact with the patient.
No pulse.
No effusion. Good lung sliding.
Hey, start compressions, Joy.
We haven't considered all the T's.
I checked for tamponade and tension pneumo.
I'm assuming they're already multiple rounds in of performing these 2-minute cycles of chest compressions. And the reason we do 2-minute cycles is twofold. One, it's very tiring to perform more than 2 minutes of chest compressions as an individual, so you want to swap off. In fact, when you're running a code blue, one of the things you have to do as a leader is assign roles. You're going to be performing chest compressions first. You're going to be second in line, ready to jump in after that person's 2 minutes are up. You're going to be keeping time when we should be changing individuals, when we should be checking rhythms, when we should be administering medications like epinephrine, amiodarone, or lidocaine. They also need to consider what are known as reversible causes of cardiac arrest. These are H's and T's that allow us to think about reasons why that person's pulse is not coming back in order to potentially treat one of those issues and then be able to bring the person back.
Faster and deeper, please.
You need a break, Joy?
And you want to allow full recoil. If you're just pushing down and you're never really allowing that full recoil, there's the decreased value of that chest compression because the heart is not able to fill, because you need to push the heart and then allow it to fill, push the heart, allow it to fill. And again, your chest compressions at best are performing 20% of what a typical heart can do on its own. So it's not a full replacement for what the heart pump can do, but it's something you can do to buy time.
Stop compressions, we're calling it. Sorry, the patient's dead. All right, who can tell me what went well?
We followed the VTAC algorithm. We checked for reversible causes.
So the VTAC algorithm is the shockable algorithm, which is pulseless VTAC or ventricular fibrillation. On their monitor, there looked to be like a little bit of a polymorphic pattern.
Should we have given thrombolytics?
No, you should have recognized that the cardiac rhythm on the monitor was polymorphic, not just VTAC. It was torsade de pointe. That's French, twisting of the points.
And it's twisting the points over the baseline, so the line that's down the middle of the EKG. But in order to make that diagnosis, you technically need to be aware of the QT interval, which is a specific measurement that you can get or the machine can give you. But you need to get that from their pre-cardiac arrest EKG or rhythm strip. It's very hard to get it in the midst of chest compressions because you're not going to get a clean strip. So in a situation like that, it's hard to be able to diagnose torsade de pointe.
Long QT antiarrhythmics electrolyte disorders.
They have no history, I'm assuming, because this is a mannequin, to know what medication this person was on that could predispose them to a long QT disorder.
Your patient would have lived if you pushed magnesium sulfate.
Good news is he's an organ donor. Parts of him are going to get used to make frisbees, water bottles, end up as microplastics in our brains and reproductive organs.
Thank you for the words of encouragement, boss.
He's making a joke, obviously. There's microplastics being found in some parts of our body. And partially, these things are true, and we're trying to figure out how to deal with this because they're kind of everywhere. They're ubiquitous. They're found in our environment. They're found in our drinking water. The issue with PFASs, as an example, is that we need more research. We had $15 million in research going to PFAS research on farmlands, and guess who canceled that research? Your environmental lawyer and Secretary of HHS, RFK Jr. So much for caring about toxins in the environment, eh?
Yeah,
Tom is a minute out.
Ooh, who wants to treat a real patient?
Why is she so salty that she did a mock code there? I don't think that's terrible, but it would be terrible if there was other things going on in the hospital, especially taking up a patient room.
Did you not get a packet from Dr. Underwood, Gloria? It outlined the quality improvement changes I instituted at the VA. We're adopting the program at all of the university hospitals. You didn't read it?
No, I did. I mean, I will. I'm going to. I want to. I thought I had a little bit more time before you came in today.
We've already distributed patient passports to everyone at registration.
What is a patient passport?
So glad you asked.
So here's the problem with quality improvement projects. Here's a potential problem of quality improvement projects. In order to practice good healthcare, you need a really good balance between thoroughness and speed. That's largely reflective of how the human body works. It works in homeostasis. You can't have too much acid, you can't have too much base. You need a really well-controlled oiled machine that is balanced. But when you're taking care of patients, especially in a hospital setting, when you put in too many rules, too many mandated tests, too many buttons to click, too much information gathering, too much administrative burden on the nurses, CMAs, physicians, physician assistants, you can actually make care worse with good intentions.
John Doe, dishwasher, penetrating trauma from a kitchen knife to the right chest.
Assault or accident?
Unclear. Initially had a pulse, lost it 2 blocks away.
So that's one of the major things that can happen. You can have return of spontaneous circulation, but in patients who have experienced a cardiac arrest, especially ones that are losing a lot of fluid, blood, they are very high likely to return to cardiac arrest, and that's why you need to get them to the hospital as quickly as possible.
1, 2, 3.
Prep for a left thoracotomy.
So what they're gonna be doing is they're gonna open the chest, literally cut open the chest, in order to get access to whatever area is bleeding to stop the bleed. Because if you don't stop the bleed, no matter how much blood you keep pumping in through the IVs, through a potential central line to get fluids and blood there faster, they're just gonna keep bleeding out internally.
What's your plan, Samira?
Chest tube to the right. Stand by with massive transfusion protocol.
I put 2 units on the infuser.
Sterile blood 6.5.
Here we let the fellows and the residents kind of take charge.
I'll hold on to them just in case.
Is the VA even a trauma center?
Not for medic runs, but they walk in. Falls, major MBCs, GSWs.
There's always this like, let's see who's tougher than who when someone new comes into the hospital. And I'm not a fan of that. I feel like we should all be on the same team, but I feel a little tension forming.
Giovanni, you're on section. Whitaker, get ready for internal compressions.
What's interesting is they're still performing chest compressions while the heart is open like that. I don't think that's effective at that point. That's why they actually told them to come in and squeeze the heart manually against the breastbone.
Heart's empty. Somebody start cardiac massage. I'll cross clamp.
Yeah, I got it. You do these one-handed, pushing up against the breastbone with 4 fingers.
Very good. Not much blood to suction.
Okay, team.
Samira, next steps.
I really like his teaching style here better. When you encourage people to make decisions, it's okay if they make a mistake because it's under supervision because they can be rapidly corrected. And when you choose your path, you are more likely to learn from that path. If it was correct, you feel good and you get reinforcement. If you get corrected by someone else, you feel that maybe not disciplined, but that correction a little bit more deeply, so you're more likely to be confident in the future with the right decision. It kind of sticks with you. But when someone's constantly just guiding you and telling you what to do all the time, it's very easy to almost tune out and just follow instructions like a robot, almost like we're doing with AI these days as humans, and not actually learn from the process. So I like his teaching method.
There's too much blood to suction.
Try to identify the source,
Could be the right ventricle.
or more likely the hilum.
Fresh lap pads.
They're talking about where the bleed is, and she said that it could be on the right side of the upper heart. He's saying that it could be at the root of the lung.
Proximal hilum is under the sternum, along with most of the right ventricle.
You need better exposure.
Convert to a clamshell.
Exactly.
Trauma shears.
Might have been nice to let them come up with that plan.
Heart's gonna need double compressions, just like this.
Right ventricle looks good.
Massive hemorrhage from the hilum.
So it looks like he was right that the bleeding was coming from this part of the lung, and very difficult to get access and make a repair there.
Clamps on. Nope, no good. Still bleeding like a stuffed pig. I can give it a
Dr.
try.
Garcia is a very skilled surgeon. If she can't get it, we need to think of something else.
Like what?
Hilar flip. You're gonna rotate the lung 180 degrees, like putting a kink in the garden hose. It'll stop the bleeding.
That could possibly work.
Or he'll die when you rip the entire lung off the hilum.
Gently.
Gently. This is so above my pay grade understanding. I could visualize what he's saying, literally rotate the lung in order to cut off its circulation. Here's a great analogy. When I've taught you before about testicular torsion, where the testicle can actually wrap onto itself and therefore choke out its circulation, that's what you're trying to do with the lung here. I imagine it's much harder in real life. I don't know why. It looked too smooth. Cardiothoracic surgeons, sound off in the comments.
Blood loss is slowing down.
That's a good sign.
Item looks dry.
Yeah, the heart feels empty.
Okay, we fixed the leak. Now let's fill the tank.
I mean, it's very temporary. Very temporary, because you can't have the lungs necrose.
Were you feeling weak or dizzy?
No. I got up to pee and I tripped over a laundry basket that I couldn't see in the dark.
Did you hit your head?
Does my chart say that I hit my head?
It's weird that he's asking about what the chart says as opposed to what's happened to him. That's already a flag in my book. Whenever you're evaluating a fall, you're trying to evaluate, is this a mechanical fall? Meaning, oh, did they slip on a rug? Did they fall down the stairs? Did they trip on something? Or is this because they syncopized and collapsed? Or did they lose their balance before just standing there? So it's an unexpected fall. And those are important things to figure out because that's gonna change your management.
Yeah, how about we focus on patching me up?
All right, Mr. Williams, we're gonna check an x-ray of your wrist and try to get you out of here as quickly as possible.
Wrist, maybe even forearm. She kind of looked like she touched his radius.
James here is gonna take you to get an x-ray of your wrist.
I'm going to be fine.
Well, it'll tell us if you need a cast.
Oh, I doubt it. I should probably go home, keep some ice on it. I know you guys always need the beds.
I'd really like to observe you for a little bit in case you did hit your head.
My head? I hit my schnoz on my arm, I think. Nothing more.
You think you don't remember?
Well, he clearly does remember because she was asking you if he hit his head before.
No. Or yes. I'm going to be fine.
This is part of the physical exam, documenting confusion, and this is clear confusion.
Okay.
Ha!
How about we take that x-ray just to be safe?
Yeah. Yeah,
Yeah,
okay. Good idea.
So, who should I pick up?
We're about to get the morning rush.
What do you mean?
Every morning around this time, the nursing homes and assisted living facilities do their morning bed checks.
So not only does this happen in the ER, but it also happens in family medicine because a lot of times we cover the nursing homes, which means that when they do their bed checks, we get paged to help decide, does this person need to go to the ER? Does this person need some sort of intervention then and there? Do they need to be brought into our office for just an outpatient visit? So this timing issue absolutely does happen.
It looks pretty quiet to me.
And there's always that gunner med student who's annoying and wants to outsmart everyone. That's actually a term we use. It's called gunner. I wonder if on Urban Dictionary they have a definition of that. It's probably gonna mean something completely different there, but.
Incoming!
Oh, like I said, come on.
Ethan Bostic, 79, found altered this morning at assisted living. No history of dementia, has a pulse. What's a pulse?
Physician orders for life-sustaining treatment.
That's actually very helpful to know whether or not someone is a DNR, meaning that they're a do not resuscitate patient. Generally, hospitals and ERs and all sorts of legal forms have variations of what a DNR is. Some say do not resuscitate, but provide full care. Some say do not resuscitate, but provide comfort care. So it really depends on that person's stage of their journey. Some may be on hospice, where in a hospice scenario, they're DNR and it's only compassionate care. So you're trying to make them comfortable, making sure that they're not experiencing air hunger, excess secretions, nausea, pain, etc.
No CPR, no intubation.
Then there's nothing for us to do.
That's not true, again, as I said.
Well, do not resuscitate does not mean do not treat. He may perk up with fluids, IV antibiotics.
And maybe, he's limiting it to two options. There could be an electrolyte disturbance that could be easily correctable. If he's having a stroke, you might consider treating that. If he's having some sort of arrhythmia in his heart, you might consider treating that.
So when did your eyes start bothering you, Miss Matthews?
Sister Grace, please. I'm only married to God.
Of course. I'm sorry.
A few days ago, I thought it was pink eye. Or maybe I scratched it while gardening.
It's a very bad case of conjunctivitis.
Conjunctivitis is pink eye, and there's so much discharge on her eye that it leads me to believe that it's likely bacterial cause, especially because it's unilateral. But the bigger issue is you have to make sure that underneath all that discharge, there's no reddening of the skin that is spreading. Because what you can develop is a preseptal cellulitis. And that preseptal cellulitis is still amenable to antibiotics. Sometimes it's an infection that requires 2 separate antibiotics. But then the danger of preseptal cellulitis is that it could change into orbital cellulitis, which that's an IV antibiotic situation, requiring imaging type situation, so much more acute.
You should send a sample to the lab to direct your treatment.
I have never sent a sample of someone's pink eye conjunctivitis for culture in order to decide treatment. I think that's happened 0 times in my over decade plus treating patients, but I guess in severe cases it can.
I'll put a numbing drop in your eye and check for a scratch with a special lamp.
I don't know why she's assuming that she might have a scratch. If she said that she was rubbing her eyes vigorously or she had some trauma, perhaps you would look. What she's putting in are numbing drops in order to put fluorescent stain into the eye with this little paper that makes the eye change color, that under a Woods lamp or this like purplish blacklight looking thing, you're able to see as that dye sets. If it sets into areas where there is damage in the cornea, you could see a corneal abrasion. Here's some examples of that.
What's up with your tooth, Louis?
It's been going on for a while, but it got bad last night. Lower left side.
Okay.
That looks like an abscess.
It could be an infection at the root. We can drain it, but then you're breathing kind of fast.
Yeah, I've been walking more.
This is a patient who has alcoholism, and as a result, alcoholism can develop issues with the heart, with the liver. Specifically with the heart, you could develop heart failure, portal hypertension, and all these things are issues that can create fluid buildup, either in the lungs or in the different cavities, and as a result, make it difficult to breathe.
What shape you're getting in is for a liver transplant.
I don't need a new liver, just get rid of this toothache.
It's interesting how some patients will prefer comfort as opposed to like getting rid of pain, as opposed to treating a condition that will greatly improve their quality of life.
One more?
Is my heart still ticking?
Like a jackrabbit.
Like a jackrabbit, meaning that it's beating too quick, he's tachycardic.
Louis, there's something I need to tell you. Last time I saw you, about 10 months ago, I treated you and I took some of your medicine.
It's always good to be honest with patients. I'm surprised he has to do that here. I'm curious if this was a corporate decision or his boss told him to do this. Also. Okay. His looks so much better than mine.
Yes.
My goal is just to act like all of these actors, so eventually I get some sort of role here, just replacing one of them for Twin Day or something.
Hey, Doc. We have a situation.
Excuse me.
I mean, I hope he signs out the fact that this guy's having difficulty breathing, dyspnea on exertion, and is tachycardic.
Someone left a little baby in the restroom.
Oof. And that's not a newborn, based on the size.
Okay, let's think about...
Oh, he's tachycardic.
Reversible causes of confusion in the elderly.
Hypo or hypernatremia, infection, but he's afebrile.
Afebrile in someone who's elderly and frail perhaps is not a clear reason to rule out infection.
VTAC, can I?
Yeah.
So remember, VTAC that has a pulse is not cardiac arrest. VTAC that's pulseless is a shockable rhythm. But this person is DNR.
No pulse. Should we call for a code blue?
No CPR. No shock. We honor his pulse and his wishes.
Hey, that's a student. Maybe you should check as a new resident if he has a pulse. Oh my God, they're just letting med students decide who lives and dies. Do you know how many times I've had a student, and myself as a student, so I'm not throwing anyone under the bus, have checked a pulse and said, I feel it or I don't feel it, and that was inaccurate because I was just too young in my career, or the student was too early in their career to know the difference, or they were nervous, or they felt their own pulse?
He looks so peaceful.
Should we maybe go find a new patient?
No, stay here.
And I'm surprised he's not calling and attending as a first-year intern to start calling DNRs while having the med student check pulses. There's a lot of things happening here that I disagree with from a hospital setting. Like if I was an administrator, I'd be pissed. You little baby.
I'll get Robbie.
Should I come with?
No, stay here. Donnie, Jesse, teach her something.
You know how to check a rectal temp on an infant?
Most important thing to do in order to check an infant is know how to take a proper temperature. And the correct way is to check a core body temperature, which is a rectal temperature.
9-year-old Kylie Connors, brought in by her dad's girlfriend, Gina. Kylie took a tumble on the stairs this morning. We submitted chin lag and a chipped front incisor. She's got lead on a pressure dressing. Bleeding pretty good on arrival.
In order to stop a bleed, sometimes you have to put extra pressure onto it, and sometimes you hold it, but if you need it to be there for a longer period of time, you can do a pressure dressing where it's actually exhibiting force, decreasing the amount of circulation, therefore decreasing the amount of bleeding.
Somebody found a baby?
Yeah, not the first time it's happened. So, about those pills I took.
Don't worry about it, Doc. If the pills helped you, great. I never really liked taking them.
I appreciate that, Louis. That's not really the point, but I need to lift up your shirt for a second.
That's ascites. When you have cirrhosis, liver failure as a result of alcoholism, you can develop excess fluid in the abdomen like that. That requires draining a lot of times if it gets infected, obviously, but also sometimes just to remove it for the ability to breathe normally. So it can become quite tense like that. You see swollen blood vessels because what happens in someone who has alcoholism, they develop increased pressure in their vasculature, which causes swelling of these blood vessels, fluid to leak out. Also, sometimes these patients have low protein levels, and as a result, that also makes water escape. So it's like a twofold problem.
You need some lab tests and a procedure to drain off some of this fluid.
Paracentesis.
I've been tapped a few times before.
3 times in the last 6 months.
You got to be careful when removing that fluid, because if you remove too much fluid without giving them some IV albumin as an example, you can create issues with the patient. So you want to make sure that you're taking out 1 to 5 liters, but if you're starting to do more, you got to start adding that IV albumin.
Hey, Santos. Our little girl Kylie has been in the West Penn emergency department a couple times.
Why is that just being noticed now? Because usually when a patient comes in, you're right away seeing the patient's chart, and you should be able to do that early on. And she was already treated, about to be let go. So I'm surprised he just caught that now.
All right, lungs sound great. Can you lean forward for me?
Ooh, that's a lot of bruising.
Did you hit your back when you fell down the stairs?
No.
Okay, there's a pretty good bruise here.
I got knocked down in soccer.
Oh no, you broke your wrist last year too, huh?
Fell with my skateboard. Got a purple cast.
Cool color. And you were treated at West Penn? Is that your closest hospital? I guess that would make sense. I've only been dating her dad a few months.
What they're experiencing is finding bruises in different stages of healing, multiple fractures, multiple hospital systems, parent not with the child, child's injuries seem out of proportion to what's being described as causing the injury, and as a result, all of these things should raise flags for potential physical abuse.
Kylie, any chance you can pee?
Maybe.
Okay. Well, with the bruise on your back, we need to check your urine.
Want to make sure that the kidneys are not damaged. In situations like this, I like to give the patients water in order to help them pee, because they give a too small of a sample, sometimes not enough.
Kylie, there are some questions that we ask every kid who comes in with an injury.
Like what?
Like, sometimes the people that you live with can get so mad that they hit you or hurt you, maybe without even meaning to.
I like asking the questions without putting blame on anyone. It's a good way to start the conversation.
How about at school, Kylie? You know, is anybody being, mean or bullying you?
No, I have lots of friends.
Well, so far she's given good answers. The thing that you also need to consider in a patient like this, because she's only had one fracture thus far, and you just so far see a lot of bruising and heavy bleeding that won't stop, perhaps there's a clotting issue that's at play here that's being missed because we're thinking about physical abuse. Again, it's something you want to think about because you want to maintain the child's safety, but at the same time, you don't want to miss a medical condition that could be causing these symptoms. Because again, a lot of bruising doesn't just mean physical abuse or trauma. It could be easy bruising due to perhaps a clotting issue or other hormonal disturbance. Blood in the urine, significant trauma, but I still need more tests to figure out why that's happening.
Well hydrated.
No obvious source of infection. Could be a benign virus, but can't assume that.
This is the abandoned baby?
Mm-hmm.
How old?
How old do you think she is?
Month and a half?
Initially, I was very confused why they were saying that the baby might have a viral issue. But then if you look at the monitor, the baby has a 101 fever. It's basically a fever of unknown origin because the baby doesn't have symptoms of a viral infection, of another infection. So you have to really do a broad set of tests to figure out why this baby's having this fever. And you would do that in a case of even a baby that's brought in by a parent with all its history intact. Here, it's even more important to do it because you don't know this baby's birth history, you don't know what the baby's been exposed to, so you need to be even more careful and perhaps order even more tests.
Under 28 days is a safe haven drop-off, no questions asked. But over 28 days is a crime, child abandonment.
I think less about that, and I think more about the medical picture. Even checking the baby's urine, because the baby can't tell you, oh, hey, I have a urinary tract infection, it's burning when I pee. A lot of principles that are used in veterinary medicine taking care of pets are used in pediatrics, especially newborns, because the baby can't tell you what's wrong, what's hurting, what the symptoms are.
Under 28 days gets everything, including an LP, but over 28 days, you can follow PCARN or step-by-step to determine risk of invasive bacterial infection.
This baby looks great.
We know nothing about the birth history. Did mom have group B strep, active HSV lesions?
Those are all really good points.
We should assume the worst.
Yeah, you'd want to do all the tests, including an LP, CBC, blood cultures.
CBC, blood culture,
Metabolic
chem
profile.
panel,
Yep.
chest x-ray.
Chest x-ray without respiratory symptoms. Oh, I don't know. You'd have to convince me of that one.
So, Mr. Williams, sometimes a fracture of the scaphoid bone doesn't show up on day one.
Fallen outstretched hand is the most common cause.
My knee hurts.
Oh, did you hurt your knee?
You didn't do a full body exam when someone fell down the stairs or however this guy fell?
I must have. What is this?
That's, for your wrist.
I need this?
Well,
What she's doing is the correct thing. She's seeing him behave erratically. You always want to be closest to the door to escape. You want to call for help early rather than later because it could be a preventive, not just a reactive measure.
Mr. Williams, do you know what day it is?
Because he has a trauma and he's so altered, I mean, I'm getting a CAT scan.
How's she doing?
Seems happy enough. Yeah.
Yeah, the clinical condition is a very reassuring factor in a baby. Vitals also very reassuring, but you need the blood tests and the rest of the tests to come back as well.
Okay. Just got a quick point of care CBC.
I'm assuming there's nothing on it.
Is there a problem? Did I miss something? Dr. Al?
I'm confused. This is actually the first episode of The Pitt that I watched before giving you my reaction. I usually watch them first time right then and there for each reaction, but I got invited to the premiere by the folks at HBO Max. So cool, so grateful that they invited us. Got to hang out with the cast who are all super friendly and said they watched the reaction. So if you're watching from the show, what's up everybody? I actually was doing a live reaction while watching it at the theater, quietly of course, to my friend Dr. Alok Patel, who is sitting to my left. But he's actually hosting an after show podcast, which we want to support, so we're linking that down in the bio. Actually, Dr. Patel and I reacted to medieval medical devices. Might as well be torture ones. Click here to check that out, and as always, stay happy and healthy.